afternoon, everyone. Welcome to today's webinar hosted by Patagonia Health. Today's webinar topic is trauma, drugs, and nervous system shrugs. Now, if you aren't familiar with the Zoom webinar platform, take a look at the control panel at the bottom of your screen. Here you can configure your audio settings, send chat messages, and ask questions. We're so excited to hear from Dr. Chitava Burton today. As a quick background about her, for more than 2 decades, Dr. Chitava M. Burton has been a steady voice for the well-being of educators, students, and the community at large. With a doctorate of education in community counseling and a focus on traumatology, she brings both academic and expertise and hands-on leadership to the complex realities of stress, secondary traumatic stress, vicarious trauma, compassion fatigue, and burnout. So without further ado, I'm going to pass this over to Dr. Burton.
Good afternoon, everyone. Thank you for being here. Again, I am Dr. Chitava Burton. I go by Tava. My first name is very complicated. But again, thanks for being here. I'm going to move right in. I know I only have 45 minutes roughly, and I know there may be some questions, and hopefully I can answer them at the end. But I have this slide up here. Imagine. I want you to imagine being asked to do a webinar on this topic and only have 45 minutes. So bear with me. I tried to put in this webinar the slides that I felt like were most important. I'm always open to answering questions outside of the webinar. I listed my email on the very last slide, and I do believe the slides will be sent out to the participants. Also, just a disclaimer, I use a lot of humor. Although this topic is not funny, I just use humor to cope and make something that's heavy not feel heavy all the time. So if I throw in a joke or something sarcastic, it's just how I operate. So I'm going to move right in. So I have warning. I have a trigger warning. I like to trigger people, not on purpose, but to get us in the mindset of trauma. Now, if we were face to face, this would go a little bit differently, but I'm going to start out for us to pretend like I have given you some paper. And on this piece of paper, on these papers, you're going to write down 3 things. The first thing you're going to write down, if we can imagine, is the name of someone that you love, or just sister, brother, aunt, uncle, I don't know, mother, child, doesn't matter who, just one person. The next piece of paper, I want you to pretend as if you are writing down one of your favorite places to go. You can just think of it. Think of one of your favorite places that you like to go. And then next, I want you to pretend like you're writing down something that you like to do. So whether it's going to the gym, whatever you like to do, whatever you like to do after work that is calming, soothing. And so the last thing, if we were face to face, I wouldn't get you to write it down. I would get you to think of it, or at least write down a symbol that represents that. But for today, instead of writing down that symbol, I want you to think of a drug, alcohol or drug, just anyone, doesn't matter which one. So we're going to go back to the person that you said that you love. Trigger warning, that person is dead. That person was killed at the place that you say that you like to go. And that event or activity that you like to do, you no longer like to do that anymore because of the death of that person. So what do you have left? That secret, that drug that you wouldn't want anyone to know that you use and or abuse. So to get us to understand and feel trauma, that is why I did that. But then also to add the substance use on top of that. So oftentimes in my experience, personal friends or even coworkers, that when people experience trauma, they cope through drugs and or alcohol. So today, hopefully, if you're still here by now, you'll understand how traumatic stress will alter the neurochemistry in your brain. and how substance use is an adaptive strategy or a coping skill, and how to apply some trauma informed approaches to assessment and treatment. Now, this is where addiction comes up. Now, what is addiction? I found just some random definitions. So, one says that it's a brain disease. Psychologist Gene Heyman says it's a choice. And then neuroscientist Mark Lewis says it's uncannily normal. So I can't hear you or see you, but out of those, which one do you think addiction may be? Personally, I don't like to use the word addiction because addiction can be sick pornography. You could be addicted to gambling. You could be addicted to shopping, to social media. So I don't look at substance use or abuse as an addiction. But if I had to pick one, I would probably say almost normal, because a lot of people, if you think about it, high stress jobs, especially clinicians or anybody in a helping role, what do people say after work? What are we going to go do? Oh, we're going to go have a glass of wine. Oh, we're going to go do this. We're going to go to a bar. We put labels on it's okay to drink alcohol, but it's not okay to go snort cocaine. And not being facetious, but that's just how we put labels on drugs, that you can drink a bottle of wine, that's okay, but you can't eat a THC gummy. So just trying to change how we look at drugs and alcohol, because it doesn't matter which one, they can still have very negative effects on our lives. So I have a co-host, Iron Man. I'll be honest, I don't watch these movies. I was somewhere and someone had this Iron Man movie on. And I said, I think he has PTSD. And as I kept watching and then I did research, I said, yeah, he does. If you look at his behaviors, if you look at how he's coping through alcohol, Iron Man totally has PTSD. So he's my co-host, and hopefully he'll do well today in helping me give you some information on trauma and substance use. So what happened to Tony Stark? Tony Stark is having intrusion or that re-experiencing. He can't sleep, insomnia, panic attacks. He's very hyper vigilant, but he's wealthy, he's functional, and he's very cherished. And so I chose him because most individuals, in my experience, are functional people. They go to work every day. They're CEOs, they're teachers, they're principals, they're supervisors. They are people who look like they have it all put together. But when they get home and behind closed doors, they'll exhibit or experience those things like Tony. And so that's why I'm using him, because his CNS, and I have the acronym, the central nervous system, he's very dysregulated. So if you look at it, the suit that he wears, that's his shield. And that's the shield that we put up every day. When I say we, I like to speak in we's, not saying that's what you do, but people have that mask on. And then when they get home, if they're experiencing a substance issue, that's when they go to. So I felt like he was a very relevant example as to using alcohol and or drugs, but to the public looking completely normal. We're going to go into the nervous system and trauma. And please excuse me if I looking down, I'm trying to monitor my time so I don't go over. Excuse me if you see me do that. PTEs, so potentially traumatic events. That's what I look at trauma. It's potentially traumatic. It doesn't mean that if you experience something that you're going to develop PTSD or any type of comorbid condition. It can be potentially traumatic. So I don't have all of them. The major ones, I have acute. So if someone has experienced an acute form of trauma, they may have been in a car accident, or maybe there was a natural disaster that impacted their community or home. Next, we have chronic trauma or sometimes toxic stress. When they say toxic stress, the ACEs, students and adolescents, children and adolescents who endure the abuse, neglect, domestic violence, incarceration of a family member, the ACEs pretty much. And then we have complex, and those will be the individuals who, let's just say you experience sexual abuse from ages maybe 5 to 18. So it's prolonged, and now it is very complex. And there are other ones. I did not list medical trauma, refugee trauma, military, bullying, insidious. We could go on and on. But pretty much it doesn't matter what type it is, it's going to have a negative impact on your nervous system. And so I have this little chart here because oftentimes what I have studied and what I've seen that when individuals experience trauma, there are other conditions. So on my left, I have psychiatric, and then on my right, I have physical. And this is not everything. There are other disorders that can go under these boxes, but typically we see PTSD, depression, anxiety. And at the bottom, I have substance use disorders. On my right, diabetes, hypertension, obesity, chronic fatigue syndrome. And I'm sure there are other ones. So as a clinician, you have to be aware if your client has both, if they're experiencing or exhibiting symptoms of a psychiatric concern, and if they are being treated by a physician for a physical concern, and how you can create a treatment plan to address that in addition to the substance use disorder. So pretty much what is happening is that the trauma, there's a threat. You feel helpless and there's insufficient healing. And so going back to Tony, he survived. People survive their traumatic events, but his body didn't know he did. And so if you haven't read Body Keeps the Score, that's a really good book to read that shows you that you could walk away from something, but your body doesn't know that you walked away. Your body is still in fight or flight. So again, he's a really good example of functional, but his body is just really just regulated. And so as a result, he's using alcohol. Why is that? The prolonged stress response. There are two substrates or two layers. You have the biological layer. You have innate traits, things that we're just born with, genetics, things that, you know, your mother or father or even other ancestors may have passed down to you. And we have our nervous system. And I have the nervous system in red because the nervous system, I'm going to say, has a sister or brother called the autonomic nervous system. And the autonomic nervous system has twins, the sympathetic nervous system and the parasympathetic nervous system. And we'll get to that a little bit later. But just knowing that plays a role in developing PTSD or not, or other disorders. Then the psychological layer, your ego, your emotions, your perceptions, your cognitions. And these two combine dictate how you may or may not respond to, again, I mentioned the acute stress or acute trauma or chronic trauma. These things, they're very different. And so again, in assessing and treating your clients, you have to take these things into consideration. Everybody isn't the same. And I don't have the stats, but even gender, men respond to PTSD differently than women. And even some certain men, certain people, I'll say men and women may use different types of substances. So those things also play a factor in treatment. Okay, race and ethnicity play a factor in these things as well. So I can't go into a lot of detail, but just keeping those things in the back of your mind when you're looking at the integration. And so I'm going to get a little nerdy because these things are really important for you to know when you're maybe trying out some strategies. The amygdala. If you don't know what it is, I'm sorry, if you know what it is, I apologize, but some people may not. The amygdala is the emotional processing, the fear, the anxiety. At work, when the kids act out, I say, hey, your amygdala is showing, cover it. I should put it on a t-shirt. I know. So that's like the smoke alarm. So you see the smoke alarm on the screen, that is a warning. The hippocampus, that's memory, episodic memory. If you work with individuals who you suspect or who have experienced trauma, they may have amnesia. They may not remember certain things that have happened to them. The episodic memory is closely tied again to the amygdala, your emotions, and it's also tied to learning. So if any of you are working with children or adolescents and they're having maybe learning challenges, you may want to ask questions about what has happened. I see it a lot. I see a lot of students with diagnoses as having a specific learning disability or having ADHD. But when you look a little bit deeper or ask the right questions, if you can, I see trauma as a recurring factor, but it definitely impacts memory. So when they're tested, of course, they're going to score very low in the working memory area. Those are just the little things for you to keep in mind. And I have the camera because the hippocampus is the memory. It's going to take the picture. I remember this. But on my left, you see a very clear picture of the young lady. But after trauma, that image is very distorted. So keeping that in mind as well when you're working with clients, how they see themselves and how they feel about themselves is very, very distorted after that experience. The thalamus, I call the thalamus air traffic control because it's going to decide what sensory information, again, right brain, the senses is what's going to be diverted or what's going to be delayed to the cortical areas. And that's just to your lobes. The hypothalamus, very important. That is the thermostat. It's going to regulate your body temperature, homeostasis. I mentioned the autonomic nervous system having twins. And so the hypothalamus is part of the sympathetic nervous system. And when you're in a constant state of stress and trauma, it's going to activate the HPA. And I have that written down. It's a very long word. It's the hypothalamic pituitary adrenal axis. I know, very long. And pretty much is the hypothalamus, your pituitary gland, and your adrenal glands all synthesizing, and it becomes activated. And it creates over time chronic inflammation. If you're familiar with Nadine Burke Harris, who I believe now is a Surgeon General in California, she gives a great TED talk about the HPA. And the HPA, because of the hormones that it releases, it it accounts for a lot of physical conditions. So when people try to say that mental health and they're the same, like actually sometimes it starts physically and then it develops into a mental health concern. So again, the hypothalamus is running even when there isn't any danger. And then the prefrontal cortex right here. This is how you make decisions, logic, and reasoning. So what happens when substance abuse and trauma get together? They fire the CEO. So the prefrontal cortex is a CEO and it's fired. And so if you think about if you've seen the movie or a little bit of it, Tony Stark, he has that intellect, but his threat system again is done. It's override. So he's not thinking. Excuse me. So what does that mean, Dr. Burton? Okay. When we talk about trauma and SUDs, dopamine is the reward system. But what happens when individuals use substances? It alters it. So it gives you a fake dopamine. We know natural dopamine, sunshine or sunlight, being creative. Certain foods have dopamine, but when they use substances, it's fake. So we have a VTA. That's where dopamine is in the brain. And the dorsal striatum, that's where our habits are. And also that gets activated for anticipation. So the anticipation of having the drug, even anticipation as far as going to buy it from a supplier or going to get it from somewhere, that is activated. The nucleus accumbens, that's important because that's a hot spot, not just for drugs, but also for any type of, again, addiction. Social media is a big one. So the same area is activated when you can't wait to get on TikTok. You can't wait to get on Instagram. You can't wait to go scroll to see what's going on in the world of politics or in the world of, I don't know, the Grammys or awards. The same areas are activated. And so, of course, cortisol, that's stress, norepinephrine, that's fight or flight. These hormones are released when there's trauma, but also with the substance abuse. So again, Tony, he's really high tech, right? But he's still stuck. Again, I see it a lot with very functional people, very well put together, but they're still stuck in survival mode. And again, I can't see you, but I'll give you a few seconds to think about if you have any clients who are stuck in just survival mode. And what does that look like? Because it's going to look really differently. Again, if I could go back to the previous slides with the biological and psychological substrates of trauma. Some people are just stuck. And so some clients may, again, have more intrusion. Some clients may be very hypervigilant. Some clients, it really depends. Some even dissociate depending upon what has happened to them and how long it has happened to them. So just think about your clients and if they're stuck in survival mode and what that looks like. And what do you, as a clinician or professional, feel you could do just based on what you know now, what I just told you, to help them move out of that survival mode? And you're probably thinking, well, if I knew that, I wouldn't be on the webinar. I know. Okay. So I always like to kind of go back to the people that we work with because sometimes they're our best case studies. I have a lot of kids who are stuck, who are in survival mode. And when I say kids, they're high school and some of them are elementary, and they do abuse a lot of drugs. And when I speak to them and ask them, there it's always a traumatic experience. A lot of times for a lot of girls, they tell me about a family member who has violated them. And it's usually like an uncle or like a grandparent, like a grandfather, and they're stuck just there. And so when they go to the bathroom to vape or actually smoke real marijuana, when we have conversations with them, that comes up a lot. And sometimes it's hard to get them out of that survival mode in my work because I need support from parents and guardians, and it really takes a village. And this is just me being a nerd, the chemical rush. What happens is that, and you can read it for yourselves, the synapses, they're how our nerves communicate. But the dopamine rewires the brain, but it rewires it to want more. And what happens when you want more, you might up the ante a little bit. You might say, okay, I'll use an example. I have someone that is very dear to me who can literally drink a bottle of tequila, a bottle, and not an airplane bottle. I'm talking about the $40, $50 bottle. That went to 2 bottles of tequila. I can't even stand the smell of it. Nonetheless, drink it. When you want more, you up the ante. And so I say, I feel like that's sometimes how people overdose is that they have this amount and that's okay, but I need more. Again, do you have clients or people that you work with, maybe even family members that, they want more, like they're up in the ante. At first it was this, and now it's getting a little bit out of control. But that's what's going on in the brain, that chemical rush, and they're getting that fake dopamine, and now they want more. And unfortunately, it can have some adverse outcomes. Clinically, you have clients who are either hyper aroused, so they're going to be irritable, they may have panic attacks. Oh, and then you have the hypo, who are numb, they may dissociate, they really don't know time, where they are. They may have odd beliefs or odd thinking. And again, I'm going to use Tony. Tony uses alcohol to control his hyper arousal. And his suit, again, is the external cover up to the others. And I really had to go back and do research. So the demon in the bottle storyline from the old comics. But from your caseloads, think about your clients who may be more hyper aroused and those who are more hypo aroused, and how they show up in sessions. How do they communicate with you? Can you tell when they're hyper or hypo aroused? So those are some things to think about. And I have this chart, and again, there's a lot of information, but just to give an example of the hyper and hypo arousal. So if you look at the substance, you can kind of look at like alcohol, marijuana, nicotine. They may be hyper. I also have nicotine under hypo because it would depend on why they're using it. If they're using it to relax, maybe after a stressful day, that might be hypo. But if they're using nicotine to intensify the effect of alcohol and marijuana, then it'll be hyper. And then what it does, the regulating effect that you can see on your screen, hopefully, the hypo arousal, the numbing, and the depression. That's what the crack cocaine, the methamphetamine stimulants as well. And even researching it, I was a little confused. I was thinking that it would be the opposite, that the crack cocaine would be maybe hyper. But as I researched and got more, I said, okay, I understand why that would happen. And again, this is just for reference. And then I have, I'm sorry, intrusion and dissociation. And this is helpful if your clients have PTSD or you suspect PTSD. The thalamic gating for dissociation, that's pretty much delirium. I had to put the clinical terms here, but I feel like when you get the slides, that this will be a good reference to go back to if your clients are exhibiting the symptoms associated with PTSD or any other type of disorder. So imagine if Tony discovered PCP, angel dust, instead of his suit. So what if he didn't present as well put together? What if he just, after that alien invasion, him surviving, he went to PCP? Yeah, it would be crazy. But unfortunately, that sometimes people that we work with or even people that we know, they try something to cope or just because, and it gets really bad. So we know that either they're going to use a stimulant or something that's going to make them a little bit more down. Again, I have alcohol is again one of those things where I feel like it's okay. But the irony is if you look at a newspaper or if you see arrest, it's always DUI, driving under the influence. So it's almost like it's okay to drink a lot, but it's not okay to use other types of substances. But most people are arrested when they're drinking and driving. Raise your hand. I can't see you. Who do you know has been arrested because they were high from THC? They want to eat. Okay. They want to eat and sit around. But it's just the label that they put on these drugs. And I can understand if I were struggling with the type of drug that was shamed by society, why I may not want to disclose that to my therapist or to a clinician just because of how society puts labels on certain things. And what happens? They want relief. So I have a PTE, and that creates some type of distress. And I want to go back to the trauma piece, distress. We talk about post traumatic stress disorder. Oftentimes, we don't talk about peri traumatic stress. So, peri, if you have watched the movie, I think it's Straw with Taraji P. Henson, and she, when we found out later on that her daughter actually did in fact die, but the entire movie is peri-trauma. It is your reaction during or directly after the event. So it's also helpful if you can to ask your clients when they experience something, what happened directly afterwards or what was going on right at that moment. I think that will be eye-opening as far as the distress part. So after that, they have the substance, they get some type of relief, and then that relief provides reinforcement, and then the cycle pretty much continues. So abstinence. So you're working with clients. I have it. They may present with anxiety. They may report having sleep disturbances, nightmares. Oftentimes, we may misdiagnose the trauma as them being resistant to therapy, resistant to their treatment. So we have to be mindful of that. And what this means, I have a question. If Tony were your patient, removing his suit without providing tools for regulation, well, his system is exposed. So again, when we're trying to get our clients or even family members to, I can't say stop, but move towards recovery, you can't just take that away and then expect for them to just say, okay, I'm okay. Because what happens, they relapse or they get sick. So just imagine just taking his suit and saying, okay, now live, cope, go. So we have to have something for that for their abstinence. I'm checking my time, y'all. Okay. Going back. So assessment. Caution. Some clients may underreport. Why? If they receive disability benefits, they may lose that. If certain things have to be reported, they could possibly lose their housing. They could lose their jobs, become unemployed. They may underreport for pain management, meaning that if they go in for surgery, the doctor may not prescribe a certain amount or a certain milligram or dosage because they know this person has a drug problem, or I don't say drug problem, struggles with drug addiction. And so they may lie about the drug. So if they're having surgery, they can get what they need. There are also legal issues. If someone is selling drugs, you probably have to report that. If they're doing things that are crimes, you would have to definitely report that. So they may not disclose certain things to you for fear of loss or fear of incarceration. For this trauma informed assessment, excuse me, and I want to just focus more on the craving. The craving is what is going to activate craving versus trauma activation. I'm sorry. So the craving is going to be, from research, it's going to be a good predictor in treatment outcomes. And from most studies that I found, and I did find one, that craving is the central construct. And I have in addiction studies because the research that I use the word addiction, even though I don't like to use that word. But what was Iron Man's suit doing for him? And what suits do your clients wear? So, what did that suit do for him? And then, what suits do your clients wear? What does that do for them? What does that do for them? Because that's going to be a good question to ask. And I know I'm using a metaphor analogy. What does that do for you? And an assessment, going back to the previous about just being cautious, to try to minimize re-traumatization. But sometimes they may not want to talk about what happened. So we have to be a little slick in getting answers from them. And then y'all know what I mean. We've been there. So assessment. I will link these assessments where you can find them if you're not already using them. The PTSD checklist, the trauma symptom checklist, the stressful life experiences screening, and the clinician administered PTSD scale, and the trauma history questionnaire. At the bottom, I have a little asterisk because that might be more so for someone who had some extreme acute stress. It may not be PTSD, but had maybe some situation that create a lot of stress, but maybe not aligned with PTSD. I have researched some of these. I use some of these in my doctorate program to assess clients. I would definitely say that the clinician administered PTSD scale was probably my favorite, but you just have to just use discernment to figure out which ones are appropriate for you and your practice and your clients. Also, under screening, when we get into substance use, the drug abuse screening test, and for diagnosis, the structured clinical interview. And if you want to know how often or how much, the addiction severity index and the timeline follow back are the suggested measures. And if you want to know if they're telling the truth or fibbing a little bit, naturally they can have a urinalysis. But I also have family input, really, really important for children and adolescents, because you're going to need parental consent and feedback from a parent in regarding about what's going on in the household or what's going on at school, the impact on life. So how has this drug, what consequences, what has happened? So has this person lost a job, lost their family? Are they homeless? I said, I'm maybe unhoused, not homeless, unhoused. I'm trying to change how I label situations and people, try to be conscious of that. Are they unhoused? And then are they ready for change? Because a lot of people are ambivalent. They want to change, but they don't want to change. They want to change, but It feels good. They want to change because their spouse or someone left them, but they like how it feels. And so the recommended assessment, the stages of change readiness and treatment eagerness scale, in all honesty, haven't ever looked at that, but I've seen it and I, of course, researched it in my studies, in my doctoral program. For children and adolescents, I have not administered these two. Of course, I am familiar with the ACEs. I give the ACEs indirectly to kids. I ask them questions in my mind. I check it off. I also give this to adults, so you can use this with adults and also with myself and my colleagues. So I feel like you have to take care of yourself and you have to know what your triggers are. And so one of the statements on the ACE is living in the house with a family member with an addiction. And if you can say yes to that and you're a clinician, that may be a trigger, especially if your client uses the same substance that maybe your caregiver use. So I feel like just being very introspective and knowing that this could be a trigger and how I may handle that. If anyone uses either the screening brief intervention, let me know how it is. I'm in a very rural area, and in so many words, we're not as progressive as some other places are. But if anyone has any information on the effectiveness of these screens, please email me. I will let you know. And just to be really quick, because I know that I have time, making sure that you regulate your clients before encouraging abstinence. And when they're regulated, they're going to be more likely to recover. Research says that first we have to make sure that they feel safe with us, that they're regulated, and then we can stabilize them. Again, going back to the person that I knew that could drink the bottles of tequila, one of the things was getting her in a place where she could not drink because we could not encourage her to address what happened to her because when she was intoxicated, and she'd be intoxicated for days and days. And again, traditional treatment can be challenging if PTSD symptoms appear when not using substances. So you have to figure out, is it here with or without the substance? Be mindful of the misdiagnoses, borderline, antisocial personality disorder, all those, they all overlap. And it's very frustrating for me because no one can really get an authentic diagnosis. And intoxication, if your client is intoxicated, do not assess them at that point. And in my personal / professional perspective, I feel like polyvagal theory, that in treatment from that lens, is about social engagement. And I've seen that when people feel connected, when they feel supported, when they feel like they have someone that cares about them, they're least likely to go to that drug. And there's a whole little video about the rats, if you can find it. And I feel like the social support and not feeling lonely and feeling connected, not just with substance use, but also with trauma or anything. When you feel like you're loved and people want you around, you may be least likely to result to that. Again, I'm preaching to the choir most likely, but therapeutic relationship, the trust and safety, again, the counter transference, just ensuring that what they're saying isn't triggering us and that we assess the substance use first and then the trauma if it's there. Secondarily, a promising practice is a seeking safety treatment program. If you're not familiar with that, I would encourage you to look into that. In treatment practice, grounding is going to be the best thing. Breathing exercises, breathing in through your nose, holding, and then blowing out through your mouth. Sleep, encouraging sleep and good hygiene, relaxation if possible. I'm pretty sure you're familiar with motivational interviewing, and that includes active listening and paraphrasing, encouraging them to build that intrinsic motivation. And again, to have social support. Takeaways, I'm going to say at the bottom, self-care is imperative. We must take care of ourselves, our clients, and whoever they need us. And again, I'm going to just reiterate that last point on this slide. I have probably no minutes But if you have any questions, hope I can hopefully answer them. And here's my email. Again, it will be sent out to you after this. And I'm going to let the moderator come on so he can.
All right, awesome, awesome. So we did get a couple questions in the chat. Nestor asks if you could please elaborate on craving versus trauma activation.
Are you craving the drug, or is it more, you think, maybe like an anniversary of something, like a death? I'm making this up. So is it, do you want this because you're just craving this, or is it because like maybe, okay, like my mom died in February? Do I want this because I'm just trying to cope? So it's like my trauma activation. I just wanted to just drown my thoughts out. I feel like there's a difference between the craving and then something that's going to actually induce me to want to go do something, if that makes sense. And if not, we can talk outside of the webinar because I know time.
Okay, I'm gonna give everyone like a minute or so if they want to type your questions into the chat and we'll try to get to them. Let's see here if we have anyone else. A lot of praise. This was a great webinar, Dr. Burton. Really appreciate you being here today. Let's see here. All right. I don't see anything in here now, but like Dr. Burton said, her email is in the slides, and definitely reach out to her if you have any questions. I'll be sending out a recording of this webinar and the slides to the email you provided for your registration of this webinar. And if this is your first time hearing about us at Patagonia Health, let me introduce us. We are an integrated EHR practice management and billing solution designed specifically for behavioral health and public health. If you'd like to learn more about us, please visit our website at www.patagoniahealth.com. And thank you everyone for joining today and have a great day.